welcome to those who are joining. It's lovely for you to be with us this evening. We have the great pleasure of being joined by Dr. Katharina Spies, who is the Medical Director of Vida Fertility Institute. And we are going to be discussing the very important topic of how and if it's possible to improve your egg quality after the age of 35. I would like to introduce our guest speaker today, Dr. Katharina Spies, Medical Director at Vida Fertility Institute.
So very nice to be here with you this evening. Thanks for inviting me. I'm Dr. Katharina Spies. I'm the Medical Director of Vida Fertility Institute in Madrid. Myself, I'm from Germany, but I've been living in Spain now for about 15 years. And that's why, because I studied in Germany, but I also did 2 years of exchange already here in Spain, in Madrid. And then I did my complete formation as gynecologist already in Spain. Since 2017, I'm completely dedicated to reproductive medicine. And since 2022, so 1 year now, I'm the medical director of the clinic in Madrid. Our clinic is specialized on international patients. So for giving you an idea, about 70% of our patients are from abroad. So only about 30% is from Spain. So today we're going to talk about a very important subject about the egg quality and the ovarian reserve. So why we have to talk about this? Because in the female, we are born with a certain number of eggs, and then this ovarian reserve stays more or less stable until our 35th birthday, and then it goes slowly down. And that's why we talk about ovarian reserve. It's something we are born with. We don't have a chance to really raise it, not like in a male that they reproduce the sperms every 3 months. But we have this reserve, and we're going to use it during our reproductive years, to say it like this. As I said, we are born with a certain number of eggs. These are millions. You see that it's about 1 to 2 millions, and this already goes down in the first years of our life. So when we come to puberty, we still have about 500,000 of remaining eggs, and in adult life it's about 300,000. In every cycle, in the end, we only use one, because only one egg comes to ovulation. But probably most of you already know that in every cycle, the body represents a certain number of follicles, from which one follicle is chosen, is selected, and this follicle grows during the first 2 weeks of the cycle and gets to ovulation. And the other follicles, which were there in the beginning, they are not selected, they are absorbed by the body, and we just lose them, or we don't use them. This egg quality descends with age, because the body we use our eggs during our reproductive life. The theory is that the quality goes down because the best eggs are used first. So the body is quite intelligent. First we use the good ones, the genetically good ones, and then in the end, when there's not so many eggs left, these are normally the ones with the worst quality. About this, we can't do anything. About the genetics, unfortunately, we can't do anything, but there are also some external factors which can have an effect on the quality of the eggs. And this is, for example, endometriosis, or smoking, or lifestyle. And this is where we can act, and where we can maybe have an influence on the quality of the eggs. So how can I know my egg quality? Egg quality is not very easy to know, because this depends on the age. Most times it depends on the age. But as I said, the ones that are left are normally the burst ones. We also assume that the higher the ovarian reserve is, probably the better is still the quality of the remaining eggs. So how do we determine the quantities of ovarian reserve? With the so-called anti-Müller hormone, which is a hormone that is produced inside the follicles. So the more follicles we have, the higher is the anti-Müller hormone. And with the antral follicle count, this is done in a scan test during the first days of the cycle. And there we just count the follicles we see in the two ovaries. The more follicles we have, the better is our ovarian reserve. Normally, we talk about a normal or good ovarian reserve if we see more than 10 follicles in the two ovaries in the scan. So, are there any other factors that have an impact on the reserve or on the egg quality? Yes, there are. This normally is also something that we can't change, or we are born with it. So, for example, women with PCOS, polycystic ovaries, normally have a higher ovarian reserve. So, in the scan, we see a high number of follicles. Normally, they are like surrounding the external part of the ovaries, and we also have higher anti-Müller hormone. But the problem sometimes with PCO patients is that the quality of the eggs is lower. It's something that is sometimes included in this syndrome. Endometriosis can also have an impact on the ovarian reserve, because this endometriosis focuses the endometriosis lesions can have an impact on the normal ovarian tissue and can destroy the ovarian tissue or have a toxic effect on the quality, and they can also limit the ovarian reserve. Normally, women with endometriosis in the ovaries have a lower ovarian reserve than other women at the same age. Of course, ovarian surgery can also give you a lower ovarian reserve because we take away in the normal tissue, or we can take part from the normal tissue when, for example, we operate for cysts or for tumors and so on. And then there's genetics. So, for example, if patients tell me that their mother or their sisters had a premature ovarian failure, or very early menopause, or problems for having children, this has to be like an alert, at least to check the ovarian reserve in the patient to be sure that everything is fine, or to start to do the fertility treatments earlier. So what can I do to improve the ovarian reserve? Unfortunately, there is not too many things that we can really do. Because, as I said, we are born with this ovarian reserve and then it slowly goes down. But what is always useful and doesn't do any harm is to have a healthy lifestyle. So this means try to not have overweight, try not to eat too much like sugar, try not to have hypertension or diabetes, things like this. Smoking also can make your ovarian reserve go down, and smoking also harms the quality of the eggs. And in the last couple of years, there's a new treatment, the so-called ovarian regeneration or ovarian rejuvenation, which can help not to improve the ovarian reserve, but to have a better result of the IVF treatments we get. So what is the ovarian regeneration? This is nowadays, I have to say that it's still quite an experimental technique, but it seems to have good effects. We know, so as far as we know right now, it doesn't do any harm, and the effects can be good for patients who do IVF treatment. So what we do there is we take a blood sample of the patient. We isolate platelets, and out of the platelets, we isolate the growth factors. And then we introduce these growth factors, we activate the growth factors, and then we introduce them into the normal ovarian tissue. So the procedure is like an egg retrieval when we do an IVF treatment, but just the other way around. We introduce these growth factors inside the ovarian tissue, and in the next cycle, we do an IVF treatment. And the theory is that in this IVF treatment, also the small follicles that maybe we even can't see in the ultrasound are activated and react to the stimulation and then start to grow as well. So the idea is to have a better answer to IVF treatments after doing this regeneration. And there are even some publications that in women who were already in menopause, for example, women with very early menopause, this regeneration could give them more or less regular cycles again. But I have to say that it's still experimental. There are no big groups of investigations so far, but we start to work with it. We started like 1 year ago to work with it, and the results in selected patients can give us good results. So good results means, for example, in a woman who in the first cycle had 2 eggs, in the next cycle we can maybe have 3 or 4. So it can make a difference. So as I said before, it's what we can do is have a healthy lifestyle, be as healthy as possible, take some vitamins. Some patients take the DHEA, which can also help to improve the quality or also to improve the response to IVF treatments. We always recommend to avoid overweight, to avoid insulin resistance, for example, in PCO patients. So there we could give some treatment with metformin or with lifestyle changes or with diets. Of course, quit smoking. If you're smoking, quit it, or at least reduce to less than 5 cigarettes, 5 cigarettes per day. And then what we can also do, and what we do quite often in Spain, is to analyze the embryos before we do the embryo transfer. So this is not that we improve the quality of the eggs, of the embryos, but what we do is we select the genetically good embryos, and like this we raise the chances of pregnancy in a transfer, and we reduce the risks for miscarriages also after a transfer. And here I brought something that is also quite new. We started working with this laboratory like half a year ago or 9 months ago. And this so-called Future Fertility, it's, the enterprise is called Future Fertility. They work with artificial intelligence in order to determine the ovarian quality. So this is something we use quite often in women who do social freezing, who before 35, or in the end you can do it whenever you want to, but the ideal moment is to do this before 35. And we can freeze the eggs in order to use them later on, to postpone your maternity. And with this, it's called Violet. What we do is before freezing, our biologists take a picture of every egg with a special camera, and this camera has an integrated computer program which works with artificial intelligence. This is based on about 30,000 eggs of patients and donors, and then the program calculates the quality of these eggs. They calculate us on one side the blastocyst outcome, or the probability we have with each of these eggs to get the blastocyst stadium, and it also calculates us the probability of having at least one pregnancy with these eggs that we just have frozen, or that we're just about to freeze. And this is something really new, but I think that it's a great option for all patients, because it's something that doesn't depend on the biologist, or it doesn't depend just on a number and your age. This is something that really depends on the quality of your eggs. And this can mean, for example, that if a patient that is 35 years old and has 10 eggs to be frozen, and we have a probability of at least one pregnancy of 80%, we can be relaxed. We can say, okay, with these 10 eggs, we really have good options in the future. On the other way around, imagine that you are 28 and you have PCO and we have 20 eggs, but they tell us, okay, with these 20 eggs, we have 50% of chances of a pregnancy. Maybe in this case, we would recommend to do another round to freeze some more eggs in order to improve this probability. So this is just for letting you know that this exists. I think it's now more and more clinics are going to start to use these programs of artificial intelligence, and it's something that that is very promising for the future.
Now we're on to the questions and answers. So thank you so much, Dr. Katarina, for that very, very insightful slides, the slides you just presented. I have learned a lot, and I have my own questions for you, and I'm sure everyone watching does. So how do people know if their egg quality is bad? What testing can be done?
So there, normally we see the quality. When we do the egg retrieval, we can have a relationship between the number of eggs that we can obtain and the number of immature eggs that we have. Well, sorry, we start with the follicles. So maybe we have 8 follicles the day we give the trigger, and then we only have 4 eggs. So there were already like 4 empty follicles. This can be related to quality and to age. And then the number or the percentage of mature eggs. So if we have a very big number of immature eggs, this can also be related to ovarian quality. Then the biologists also tell us, because they check the eggs in the microscope, they can tell us, okay, this was very regular, no fragmentation or no like extra cells on the surface that could tell us that this egg is not too well. And then now we started to use the artificial intelligence, which is not a person that tells us this is good or this is not good, but a computer program. This helps also quite a lot. But in the end, it depends mostly on the interaction of egg, sperm cell, and then the embryo that is created. So sometimes, for example, we see that if we work with donor eggs, it sometimes happens that the egg quality of the donor is good, the sperm quality of the male partner is also good, but they don't interact well one with the other. And then we maybe only have one blastocyst, or we don't have blastocyst. This sometimes happens. It's not normal, but it happens. And then if we change the donor, the egg donor, and use the same sperm from the same male couple, and we suddenly have a very good number of blastocysts. So then we see that it not only depends on the quality of egg and sperm cell, but also of the interaction. And this is something that you can't know before. Impossible.
Mm-hmm. Nutritional tips to improve egg quality. People talk about 3 months preparation, don't they, as a benchmark? Do you agree with that?
Yes, can be. It's true that in a male it's easier to say, because then we know that every 3 months the sperms are reproduced. In the egg quality, it's more difficult, because we don't really know the real impact on this. But I think the 2-3 months of healthy lifestyle can already change the quality of the eggs, can change the answer on like reproductive medicine, on techniques of reproductive medicine. This is also, for example, in women who don't have regular cycles, so who don't have regular ovulations because of PCO or because of overweight. If they start to lose weight, if they start to reduce the insulin resistance, after 2-3 months, some of them start to get regular cycles, and then you can have a normal natural pregnancy. So in these cases, in these concrete cases, 2-3 months can already change a lot.
Mm-hmm. Yeah, fascinating. Thank you. In your slides, you touched on DHEA. What are your thoughts on that? And would you mind explaining to people what that is, please?
So DHEA, it's a hormone that is like part of the the male hormones, like the testosterone part, and this can help to improve egg quality. This is egg quality and the response to the treatments, so to raise the number of eggs we can obtain. It's the same with testosterone. Maybe sometimes, so DHEA, it's pills. It's taken orally. They will recommend to take it at least 2-3 months in order to see maybe an improve on the answers. And there are also some studies about testosterone treatment, for example, testosterone gel before we start the treatment, and this can also help, like, to have a better response and maybe a better quality. But it's true that in medicine we always like to base everything on statistics and on really good investigations on evidence-based medicine. And with this kind of treatments, we don't have so far like really big investigations or really big studies that say, okay, yes, this is going to work and this is going to help. But it can help. It doesn't do any harm. So far we know right now that DHEA, testosterone, also like treatment with inositol and so on, it doesn't do any harm and it can help.
What about CoQ10?
A little bit in this direction as well. So this is something that is more used by nutritionists than prescribed by the doctors. But I think the same, it doesn't do any harm and it can help in selected patients.
Mm-hmm. Would you suggest that patients who come to you see a nutritionist as well to complement their cycle?
Yes, I think it's something that can help. So if it's a patient with really regular cycles, a healthy lifestyle, normal weight, no insulin resistance, I think it's probably not the first step I would take. But in women with maybe irregular cycles or with insulin resistance, PCO patients, I would definitely recommend it.
How do you know if you're insulin resistant?
So this is quite an easy test. It's called a HOMA index, which is a blood test. And then we calculate the relation between glucose and blood sugar and the insulin level. And then if it's raised, if it's more than 2.5, we talk about insulin resistant. And then in this case, what we normally do is we prescribe metformin, which is oral medication, and we also recommend to go to an endocrinologist to have like a follow-up, to have better surveillance, to have maybe some diet advices and so on, and to reduce this insulin resistance. And with this, we can improve implantation, so we can have a better preparation of the uterus, and we can also improve the response to the treatments in what is a number of eggs and the quality of eggs.
You talked about PGTA. Would you recommend patients over 35 at Vida have their embryos or blastocysts tested?
From 35 to 37 to 38, I think it's not strictly necessary, but from 39, 40 years on, I normally recommend it, or at least I explain that this possibility exists. It's true that patients sometimes say, but if I only have 1 or 2 blastocysts, why should I not just do the transfer and wait? So I think it's also an option that is okay, but it's true that in selected cases, so for example, in patients who have had a lot of transfers without any ongoing pregnancy, or a lot of miscarriages, or even maybe Down syndrome in a former pregnancy, or if the sperm quality is very bad, and so on, then normally we recommend genetic testing before we do the transfer. And then from women over 41, 42, we normally also always recommend it, because there really the chances of having a healthy embryo unfortunately go down. And by selecting this healthy embryo before we do the transfer, we can avoid a lot of transfers that or would not give us a positive pregnancy test or would give us a miscarriage. So, but in the end, we can do it in any moment. So there are also patients who are 32, 33 years old and have a very good number of blastocysts, and they say, okay, can I test them before and then only transfer healthy embryos? And of course, you can do it.
What does it mean in terms of timing when a patient comes to you? Because I presume it takes a few weeks, and so they can't have a transfer fresh on that cycle.
Exactly. So if we do the genetic testing on the embryos, we can't do the fresh cycle. So what we do is on day 5, sometimes on day 6, we take the biopsy of the embryos. Afterwards, we freeze them, and then we wait for the result. The result arrives about 2 to 3 weeks later. And normally we have it out after 2 weeks, but we always say let's wait 2 or 3 weeks. So what we normally do, that we can also decide together with the patients, is or we wait for the result and then start the preparation. This is the strategy we use if we have a low number of blastocysts, or if the woman is already like over 40, for example, where we think that the chances of really having a healthy embryo are maybe already low. Or we can directly, after egg retrieval, we wait for the menstruation, we do a scan, and if the patient feels well and the scan is fine, we can directly start the preparation for the transfer while we still wait for the result of the testing. So this is our 2 strategies, and we really talk about it with the patients and see what they prefer. There's also the option to do the so-called embryo banking. This is interesting as well for patients with low ovarian reserve, and this means that you do several cycles of IVF, so of stimulation, and to collect a good number of embryos, and then do the testing only once. Because the problem of the genetic testing is as well that it's not cheap. So when we do embryo banking, what we do is we do the simulation, we do the biopsy on day 5, we freeze the embryos, and we freeze the biopsy. Then we do a next cycle, freeze again the embryos and freeze again the biopsies. And once we have a good number of biopsies done, we analyze them all together. And like this, we only have this waiting time once, and we also only pay the genetic analysis once.
Makes sense. Do you ever do day 3 embryo transfers if you're worried that a patient's come overseas, for example, and you are concerned that the embryo or embryos may not reach day 5?
We really try to avoid it because we think that embryos that don't reach blastocyst stadium in a good laboratory, in a laboratory of good quality, normally if they don't reach a blastocyst stadium, they also don't give us an ongoing pregnancy. So we prefer to wait the 5 days of the laboratory to put the embryos inside, for example, inside the time-lapse incubators, to wait for the 5 days, and then do the transfer of embryos in the blastocyst stadium.
Okay, great. And any difference between frozen embryo transfer success and fresh?
No. In the studies that we have nowadays, really the chances of pregnancy are the same because the quality of the embryos doesn't change by freezing and thawing them. And so the chances are the same. There we also really relaxed and sure that it doesn't make any difference.
Thank you so much for all of your responses this evening. You've been so thorough and it's been extremely insightful. I hope that we've answered everyone's questions. Please contact the team at Vida Fertility Institute, who would be very pleased to take your questions and book in for a consultation, no commitment as it says there, to speak to the team for personalised treatment plans. So please do get in touch with the email address there, or you can email us and we can put you in touch, or via DM. So thank you so much, Dr. Spies, for your time this evening, and it was a pleasure speaking with you.
The same for me. I hope to see you very soon.
Definitely. Thank you, everyone, for joining. Bye-bye.